Your moderator for the evening. And hello, whether you are a veteran or a service member or an ATA member or guest, welcome to the American Tinnitus Association webinar series. You'll hear two great speakers and learn why funding and trials with the Department of Defense are so important. The title for tonight's program is A Salute to Veterans and Service Members. On behalf of all of us at ATA, we extend our heartfelt gratitude to all past and present American veterans and service members. We thank you. We honor you. And as the title of this program says, we salute you. We also want to recognize all the families and loved ones of veterans and service members for the unique sacrifices you make in support of our country. And last but certainly not least, we want to thank all of our loyal ATA members and guests who are joining us tonight. It is truly an honor to serve you. Americans strive to take care of our own and those in need. The American Tinnitus Association is proof of this. ATA remains fully committed to finding multiple cures for tinnitus and hyperacusis by funding research, advocating for resources and awareness, and improving the lives of veterans, service members, and all people who have these conditions and symptoms. And you will hear me say tinnitus and tinnitus in the same webinar. Both are medically correct pronunciations for tinnitus or tinnitus. Here are three examples showing the wide-ranging effects of tonight's webinar topic. Since 2007, tinnitus has switched places with hearing loss as the top health complaint, respectively, among U.S. military veterans overall. The most recent VA statistics show nearly 1.5 million veterans with tinnitus. There are not statistics for service members, so that we don't know yet. But 60% of veterans returning from Iraq and Afghanistan come home with tinnitus and hearing loss due to noise exposure during service. So clearly, the mission of this webinar is more than a salute. We hope to raise awareness of this issue and offer potential solutions and resources too. ATA is thrilled to feature presentations from two research experts who are both passionate as well as proven in treating veterans and service members. But before we get to Dr. Lynn Sherlock and Dr. James Henry, here are some quick tips for the webinar itself. In viewing the webinar, you may enlarge the screen by pulling down on the corner or by pulling the corners of the video. Whenever slides are being shown, the webcam view of the speaker automatically becomes smaller, so there's nothing wrong with your screen. This webinar is being recorded, so don't worry if you missed anything. You don't need to really take notes. We will supply the full presentation to you. The complete video and script will be posted in the members section at ata.org. All ATA members will receive an email alert when it is available. Time permitting, there will be a question and answer session. This is one of the most popular parts of the program. Simply use the question feature in the control panel to submit what you'd like to ask. We will not be able to get to everyone's question. However, ATA does care, so please submit your questions. We may be able to answer them on our website or in the Q&A column in our magazine, Tinnitus Today, or during the future webinars. If you lose your audio or video connection, just click the same link and dial in information you used to join the webinar. For technical difficulties, contact Citrix Customer Support at 1-888-646-0014. You might note this number, 1-888-646-0014. And I need to be clear, ATA does not endorse or recommend any product or treatment. Tonight's presentation and information covering tinnitus research, treatment, and management is for educational purposes only. So please do not make a mistake and think that any references as an endorsement for any treatment or device. We do not show preferential acknowledgement. So now to handle our poll, I'd like to introduce you to Thomas Baldrick, an ATA member. Thomas, if you would share with us a little bit about the poll and introduce yourself to our members.
Thank you, Melanie. Hi, I'm Thomas Baldrick. In becoming an ATA member, I feel good about doing something for myself, for our veterans and service members, and for all of you by contributing to research, advocacy, awareness, and support. My tinnitus and hyperacusis was caused by a car accident, not military service. But in my career as a television journalist, I've been honored, truly honored, to work with military heroes from the Iraq War POWs to generals, admirals, and countless patriotic men and women of all ranks who have bravely served our armed forces and our country. Tonight's ATA Salute to Veterans and Service Members is unique. It focuses on real-life challenges which don't make enough noise. Our poll now helps us know who is on the line with us tonight. The question is, which best describes your interest in this webinar? Please select one of the following. 1, I am a veteran or service member with these conditions. 2, I am a loved one of a veteran or service member. Or 3, I want to learn more about research in these areas. Please respond now. And while we take in your votes, let me quickly share some interesting information. About 1 million audiology procedures are performed every year on active duty service members. The VA now pays tinnitus disability to more than 1 million veterans, and that number is increasing. And when you consider military budget cuts along with rising disability costs, it's no wonder military spending on tinnitus research is down, thus making the importance of ATA's work even greater. So here's our poll results. 65% say I want to learn more about research in these areas. Second is I am a veteran or service member with these conditions. Thank you all for being with us. ATA welcomes all of you. And in a moment, our first research expert will present some powerful information for you. And after that, I'll have a powerful idea for you to consider for how you can help a veteran or service member who could use it. Back to you, Melanie.
Thank you, Thomas. ATA is dedicated to serving all our members and helping those in need. In fact, ATA has worked diligently with the National Institute of Health, the NIH, and the Department of Defense, the DoD, to advocate for research funding toward tinnitus through Congress. ATA has been doing its part to advocate for you. It is now my pleasure to introduce Dr. LaGwen Sherlock, a doctor of audiology. She is a research audiologist with the Army Public Health Center stationed at Walter Reed National Military Medical Center. Prior to joining the research team at Walter Reed, she served as director of clinical audiology at the University of Maryland Medical Center. Dr. Sherlock has spent over 25 years as a clinical audiologist, with an emphasis on the evaluation and management of tinnitus and hyperacusis for the past 10 years. She is an adjunct faculty member in the Department of Hearing and Speech Sciences at the University of Maryland, teaching graduate courses on hearing aids, including management of tinnitus with hearing aids. She received her Doctor of Audiology from the University of Florida and her Master's of Arts in Audiology from the University of Maryland. The American Tinnitus Association is proud to have Dr. Sherlock on our board of directors. She has published and presented in the area of amplification, psychoacoustic, sound therapy, tinnitus, and hyperacusis evaluation and treatment, and pediatric audiological assessment. Ladies and gentlemen, Dr. LaGwen Sherlock.
Good evening, everyone. Thank you, Melanie. Let me get my slides up here. All right. So it's my pleasure to be here with you tonight. As Melanie mentioned during the introduction, I've spent 25 years working with patients, and over the past past 10 years, I've really focused on helping patients with tinnitus and hyperacusis. So my patients come to me reporting problems with sleep, problems with concentration, feeling depressed, or feeling anxious, and these are really the hallmarks of bothersome tinnitus. These are, in this role now that I have as a research audiologist, I have the opportunity to look at some of these relationships between tinnitus and sleep and concentration. So tonight I'm going to focus on some work I'm doing looking at the effect of tinnitus on concentration. I think there's a real potential to use this information to help with deciding on which treatment to go with and also look at how well treatment works. I want to take a moment to acknowledge my collaborator. Dr. Doug Bungard is the chief scientist at Walter Reed. He and I are working on this project together. And I have my government disclaimer that the views I'm expressing tonight are my own and not those of the government. So let's talk a little bit about what the problem is. So I mentioned over the years I've had patients reporting problems with sleep and concentration and mood. In terms of concentration, I've had patients say that I have trouble going to work, I have trouble getting my work done, I have trouble with the quality of my work, I can't read a book or a magazine or a newspaper anymore because I just can't concentrate. So I'm guessing that most of you who have bothersome tinnitus have experienced the same kinds of problems. And in fact, 80% of people with tinnitus report difficulty with concentration. This is according to the Tinnitus Archives, which is a very large database of information from over 1,600 people with tinnitus. So poor concentration affects your ability to read, your ability to do puzzles, your ability to analyze. And these are critical skills for day-to-day functioning. So tinnitus really has an impact on how you function every day. So how do we evaluate concentration? Right now, we don't have any really good objective ways of measuring the impact of tinnitus. So tinnitus doesn't show up on a regular hearing test. And so what we rely on are questionnaires, and there's a lot of great questionnaires out there that look at sort of subjectively how tinnitus affects you. But those subjective questionnaires may not be sufficient to determine treatment efficacy. So I want to look at how we could evaluate indirectly the effect of tinnitus on an individual. I apologize, I have a dog barking in the background and nobody to quiet her. Hopefully she's not too loud. So it follows that if we could look at concentration using tests of memory and attention, perhaps that would be helpful in figuring out the effect of tinnitus on concentration. Have you ever had the experience of making cookie dough from a recipe, and somebody interrupts you by asking a question, and you get distracted, and you accidentally put a tablespoon of baking powder in the mix instead of a teaspoon? Well, I have, and those cookies tasted pretty bad. Another experience you may have had is driving to an unfamiliar destination, and you have an acquaintance in the car, somebody you don't know very well, who you're trying to make small talk, and did you miss any turns when trying to get to that destination? So we can evaluate concentration using tests that require your ability to focus your attention or divide your attention. And some of these tests include the Stroop Test, the Flanker Test, and the one-leg stand. So I'm going to tell you more about the Flanker Test and the Stroop Test, but just out of curiosity, if you've never heard of the one-leg stand, this is actually one of 3 standardized field sobriety tests. So it requires the driver to stand on one leg and lift the other leg about 6 inches, and they have to count starting at 1,000. So it's 1,001, 1,002. But it's very difficult to do that task if you're under the influence of something, because you've really got to concentrate balance, and you've got to concentrate to count at those high numbers. So the Stroop Test is a cognitive test that's used clinically to evaluate ADHD, ADD, brain damage, mild or early dementia. And so this is what the Stroop Test looks like. Some of you may have seen this test in some form or another. And so in the left block, what you see here is you're asked to say the color that the word is printed in. So in this example, the word blue is printed in the color blue. And so we call this a congruent condition because the word and the color are the same. In this box on the right, again, you say the color that the word is printed in. And in this example, the word blue is printed in the color red. We call this an natural response, we have a lot more practice reading words than naming colors. So in the congruent condition, we're more likely to answer very quickly. And in the incongruent condition, we have to sort of suppress that natural reading response, which is the distractor, in favor of naming the color, which is the target. The flanker test is also a cognitive test that operates pretty much similarly to the Stroop test. And so it's just a series of arrows, and your job is to tell us which direction the target arrow is pointing. So the center arrow is the target. We're looking at how quickly you can respond and how accurately. So this is just indicating the target arrow, and in this situation, the target and the flanking arrows, the distracting arrows, are pointing in the same direction. We call that a congruent condition. And in this sample, the target is pointing in the opposite direction, and so it's a little bit hard. You've got to sort of suppress that distraction of those flanking arrows. So again, we're looking at how much time it takes. So generally, it takes longer to respond to incongruent conditions than to congruent conditions. So your concentration has to be good enough to suppress or ignore the distractions of those other arrows. So in our study, we used the flanker test rather than the Stroop test, so that we didn't have to worry about color blindness or reading skill as factors that might affect performance. Let's talk now about attention and memory. Another way to evaluate attention or memory is evaluate attention or concentration is to test memory. We have to pay attention to things to remember them, and distractions make it harder to remember. So if you weren't paying attention and your spouse asked you to bring home some bread, milk, butter, and eggs, and you got distracted by a car going by or something going on the TV, you might only hear bread, milk, and butter. Other things we try to remember on a day-to-day basis is the phone number that somebody gave us or the date of an appointment because we didn't write it down. So the kinds of things that tend to distract us from remembering things that sort of redirect our attention, things like pain from a headache, from being too hot or too cold, or having tinnitus, that's a physical discomfort, or background noise like a baby crying or dogs barking or having tinnitus. And so we can use memory tests to kind of look at attention and concentration. So in our study, we used a test we call a letter location test. And this is what it looks like. So it's a 4x4 grid with random letters. It could be up to 9 letters. And you have 4 seconds to memorize what the letters are and where they are. And then we ask you questions about what the location of those letters. And we're looking at how accurately it tells us how many letters you can remember. So one type of question might be, which letter was in this box? And so if you were paying attention, you'll remember that this letter was the letter D. Another kind of question we might ask is, where was the letter A? In this example, the letter A was in the first column in the second row. And you may have noticed that we use uppercase letters in the grid itself, and we use lowercase letters in the question, and that's very intentional because we don't want any pattern recognition. So the question is, can we measure the effect of tinnitus on attention? And the answer is yes. Several studies have shown that people with bothersome tinnitus have slower reaction times and remember less information than people who don't have tinnitus. So that was the basis for the study that I'm about to describe. So at Walter Reed, we see active duty service members, retirees, and family members. So when somebody reports having tinnitus, they might be referred to the Progressive Tinnitus Management Program. So you'll learn more about this later on in the webinar when Dr. Reed describes this program. So anybody being referred to Progressive Tinnitus Management is invited to participate in this study. We also are seeing people without tinnitus, our control group, and they are matched for age and hearing to people in the tinnitus group, because age and hearing can affect performance on reaction time tests and memory tests. So we want to rule those out as the reason people with tinnitus are doing more poorly. So in our study, our participants did the flanker test that I described, and they did the letter location test under 3 different auditory conditions. First, they did it with no sound in the background, which means that People in the control group did it in silence, and people with tinnitus had their internal tinnitus noise. Another condition was with white noise that was adjusted to a soft volume. So people with tinnitus were directed to set it to a volume just below their tinnitus, kind of the way we use sound therapy for tinnitus treatment. And people without tinnitus were just directed to set it to a comfortable but soft volume. And then the third condition was two people talking in the background, so kind of distracting, and they set that volume to a level they just comfortable. So it's kind of like what they would listen to TV at. Now, for all of our patients, we did look at their sleep characteristics and their mood, since these are also factors that can affect performance on reaction time tests and memory tests. So this is a chart displaying the sleep characteristics of each group. Since people with tinnitus often have problems with sleep, anxiety, and depression, we really wanted to look at that between the two groups. So our participants estimated the amount of sleep they get each night. So that's these two bars here, the sleep quantity. And so it was a scale of 1 to 4. So if you were getting less than 4 hours of sleep a night, it was a 1, and more than 8 hours of sleep a night is a 4. And you can see the control group is the maroon bar, and the tinnitus group is the gray bar. Not much difference in how much sleep they get. We also asked everybody to rank or rate the quality of their sleep on a scale of 1 to 10, where 1 is not good at all and 10 is very good. And the control group rates their sleep quality a little bit better than the tinnitus group. Only about a 1-point difference in that rating. Now, we screened anxiety and depression on everyone using the hospital anxiety and depression scale. This is just a screening test. It is not used to diagnose anxiety or depression. It's to determine whether or not somebody needs referral to behavioral health. The anxiety scale goes from 0 to 18. The depression scale also from 0 to 18. And the cutoff for referral is a 10. So both of our groups were well below that referral rate, and that was actually expected because we were recruiting people specifically who were not taking medication for depression or anxiety. So we could rule that out as a confounding factor. But you will see here our control group, their anxiety levels a little bit lower than our tinnitus group, and same for depression. And anxiety rates are a little bit higher than depression in terms of screening and how people respond to those questions. Okay, now on to the actual results from the study. So this is from the Blinker test. First, let me orient you here. The Y scale represents the reaction time. So the higher the number, the longer it takes, the longer the reaction time. The bars on the left are the congruent trials, where the arrows, the target arrow and the flanking arrows point in the same direction. And the bars here on the right are the incongruent trials, where the target arrow is pointing in the opposite direction of the flanker. So as we expect, the congruent trial reaction time is faster than the incongruent trials. And then if we look at the two groups, the control group are the maroon bars, tinnitus group are the gray bars, and you can see across all those conditions, the tinnitus group is generally slower than the control group. So this is consistent with previous test findings. There's a little bit of difference in the function of the noise condition, but consistently across groups, people with tinnitus are slower. Then the letter location test, we looked at this a couple of different ways. First, we looked at sort of how many letters they could remember, and came up with some average number. And so our control group remembered a higher average number of letters. You see that represented here on the y-axis. And the tinnitus group remembered fewer, an average lower number of letters. And this is consistent again with previous results. But then we looked at how accurately people remembered the location of the letters as a function of that auditory condition. And so what you see here, this is the percent correct performance, how many letters they remembered correctly. And in quiet, the two groups are about the same. They're right around 70% correct. And in noise, the two groups are about the same. The very interesting difference shows up here when we have those two talkers in the background. Tinnitus people perform much better than the people without tinnitus. And so we think the reason this might be happening is that people with tinnitus are already so distracted by their tinnitus that adding a distractor like people talking in the background doesn't change performance. or it has a big impact on people who don't have tinnitus. So what does this mean for people with tinnitus? Well, these kinds of tests may have potential as a prognostic indicator of sound therapy. So when I would sit with patients and talk about using white noise sound generators versus using music therapy, it's very hard to predict how well somebody's going to do with one versus the other. So if we could find some objective tests that kind of give us that information on the front end, that might be very helpful and efficient for deciding the best route to go in terms of sound therapy. And also, this kind of objective testing might give us a better way to evaluate how well treatment is working. So again, thank you very much. I appreciate the opportunity to be here. If you have any questions about the study, any questions about tinnitus in general, please feel free to email me. I'm happy to respond. Thank you very much.
Well, Dr. Sherlock, thank you so much for being here and for sharing that informative information. I'm sure that's an area that many of us have wondered about and how it affects us on a daily basis. So thank you for your excellent and enlightening presentation. And before Dr. Henry begins, I'd ask Thomas to quickly say a few words on research and ATA. Thomas?
Thank you, Melanie. That was great, Dr. Sherlock. Tonight's standard $25 webinar fee was waived by ATA for veterans and service members, but the mission and the research needs continue. Since 1980, the American Tinnitus Association awarded its first research grant. The organization has directly contributed over $6 million in seed grants to tinnitus investigators around the world. ATA's ability to fund research comes from the generosity of our membership and donors. So thank you. If you are not already an ATA member, we ask you to join. You can do it easily on the ATA.org website or by calling ATA directly. You will be supporting research leading to new treatments and cures for tinnitus and hyperacusis. A membership donation is just $40 a year. You will get continued access to ATA's exciting lineup of webinars. You will receive the customized magazine, Tinnitus Today. The current issue is available to download free during this webinar by clicking on your control panel at the bottom where it says handout, so you can check out the magazine. Plus, by becoming an ATA member, you gain access to the member section on ATA.org. This has tons of archived material and the Progressive Tinnitus Management Program to use whenever you want. Now, here's the idea I mentioned earlier. Our brave veterans and service members rely on virtues like honor, strength, and pride in putting our country first. Maybe you know a veteran or service member who could benefit from an ATA membership, but you know this person won't do it for themselves. Giving them the gift of an ATA membership is just $40. Once again, it helps advance research toward a multitude of solutions for them and all of us. Thank you.
Well, Thomas, what a great idea. And with the holidays coming up, what a great way to remember someone that is serving our country. So thank you for that great idea. I appreciate it. And on behalf of ATA, I want to personally thank all of you for your kind donations. They do make the difference. And speaking of making a difference, it is time now to introduce our next presenter, James Henry, PhD. He doesn't just have veterans and all tinnitus patients on his mind. He has you in his heart. You see, Dr. Henry himself has had tinnitus for 40 years. He has devoted the last 22 years of his career strictly to tinnitus research, including clinical trials. He serves on the faculty of the Oregon Health and Science University and Portland State University. Based at the VA Portland Healthcare Systems National Center for Rehabilitation Auditory Research in Portland, Oregon. Dr. Henry is credited with helping countless veterans and service members. He led the team which pioneered the Progressive Tinnitus Management Program and the Tinnitus and Hearing Survey. He was co-principal investigator for the study that developed the Tinnitus Functional Index. These keys to an individualized patient approach are used in VA and Department of Defense clinics nationwide. Earlier this year, Dr. Henry's efforts in advancing tinnitus treatment and management earned him the prestigious Paul D. Magnus Award. It is the highest honor any rehabilitation investigator can achieve from the VA's Rehabilitation Research and Development Service. Now, all of us at ATA are honored to have Dr. James Henry tonight to join us. Now, in this presentation, Dr. Henry will be by audio only, so please listen intensely, and you will hear a great presentation. Dr. Henry, please join us for this special webinar.
Thank you, Melanie. That was a very kind introduction. And I do appreciate the opportunity to make this presentation, which is based on many years of research here at the VA. My position and most of my research at the National Center for Rehabilitative Auditory Research, or the NCRAR, is supported by VA Rehabilitation Research and Development, or R&D, service. And the views that I express do not necessarily reflect those of the VA or of the federal government. Standard disclaimer. This photo shows where I work and whom I work with. The NCRAR consists of about 50 individuals, many of whom are pictured here. The main building for the VA Portland healthcare system is pictured in the background. So I'm going to squeeze a lot of material into this 15-minute talk. We'll start with an overview of veterans and tinnitus. I'll then discuss recent tinnitus management guidelines based on research evidence. Then I'll briefly review recent studies completed at the NCRAR. Finally, I'll provide some recommendations for tinnitus management that are based on all of this research. Let's start with veterans and tinnitus. To describe the problem of tinnitus, we use Dr. Robert Dobie's tinnitus pyramid concept. The double arrow on the left shows that about 10 to 15% of all adults experience tinnitus. The pyramid shows that about 80% of these people, shown in the bottom of the pyramid, are not particularly bothered by their tinnitus. 20% in the upper part of the pyramid are bothered, and they can be mildly bothered, they can be moderately bothered, or severely bothered. And some are even debilitated by their tinnitus. So clearly, different people have different levels of need. The VA considers tinnitus to be a disability, and veterans can apply for a service-connected tinnitus disability award. This chart shows the number of veterans who have been awarded a service-connected disability for tinnitus. As of 2015, almost 1.5 million veterans were service-connected for tinnitus. In this 1 year alone, over 150,000 veterans received a new tinnitus disability award. We're now going to discuss tinnitus management guidelines that are based on research evidence. It goes without saying that clinical management of tinnitus should follow evidence-based guidelines. The highest standard for such evidence comes from randomized controlled trials, or RCTs. Evidence-based guidelines for clinical management of tinnitus did not exist until fairly recently. Cochrane reviews are publications that evaluate different methods of treatment for different conditions. There are thousands of these reviews in existence. Since 2010, 3 Cochrane reviews have been published on tinnitus treatment. These are rigorous reviews of the research literature that focus on randomized controlled trials, RCTs. They are generally thought to reflect the highest standard in evidence-based care. Cochrane reviews in 2010 concluded that cognitive behavioral therapy, or CBT, has the strongest research evidence, and that the use of sound as therapy for tinnitus has not been proven on its own to be helpful for people with tinnitus. Sound therapy combined with counseling was, however, considered helpful. A Cochrane review in 2014 evaluated hearing aids for tinnitus management, concluding, quote, "There is currently no evidence to support or refute their use as more routine intervention for tinnitus. AAO-HNSF stands for the American Academy of Otolaryngology Head and Neck Surgery Foundation. They put together a 23-member committee, including myself, to develop these guidelines. They relied on the literature, including the Cochrane reviews, to develop their guidelines. The AAO-HNSF guidelines should be considered the standard that guides evidence-based clinical services for tinnitus management. You can read these guidelines for yourself. They are available for free on the internet. Also, the ATA published a story summarizing the guidelines, which I'm sure they would be happy to provide. I'll briefly describe their recommendations. First, they suggest that any person with tinnitus be examined by an ENT physician, an otolaryngologist. Second, they suggest a hearing evaluation by an audiologist only if the tinnitus has been experienced for over 6 months, if it is heard in only one ear or one side of the head, or if the person also has hearing loss. Third, they say to distinguish between bothersome and non-bothersome tinnitus. Recall the tinnitus pyramid, which makes this distinction. They also recommend that if tinnitus is bothersome, determine if it is persistent or recent onset. Persistent would be greater than 6 months, and recent onset would be less than 6 months. Fourth, patients should be educated about evidence-based options for treatment. Fifth, if there is hearing loss, then a hearing aid evaluation should be conducted by an audiologist. Finally, they recommend cognitive behavioral therapy, or CBT, if treatment is needed. They also recommended things that should not be done. They said any kind of imaging, such as MRI or a CAT scan, is unnecessary for most patients. They said pharmaceutical medications should not be used because no drug has been proven effective for tinnitus. They said do not use any type of dietary supplement such as ginkgo biloba, melatonin, zinc, and many others that are promoted on the internet, radio, and TV. Finally, they said do not do transcranial magnetic stimulation, which is a promising but only experimental technique to this point. They said there's limited but not strong evidence for anyone with tinnitus having a hearing evaluation by an audiologist. They also said there was limited evidence for sound therapy, which could include masking, hearing aids, ear-level sound generators, tinnitus retraining therapy, and many other methods that use sound as therapy. They noted there is no evidence that any one method of sound therapy works better than any other. And then finally, they could not decide about acupuncture, whether it works or not. So we'll now shift gears and talk about research that has been completed recently here at the NCRAR. As background, we have had at least 30 funded studies since 1995 focusing on some aspects of tinnitus. As we all know, tinnitus cannot normally be cured. There are many labs around the world that are working toward discovering a cure. Our focus is to help people to manage their tinnitus and live a normal life in spite of their tinnitus. It is not the sound of tinnitus that's the problem, it's how people react to the sound that's the real problem. Those who react to tinnitus are the 20% on the tinnitus pyramid who have bothersome tinnitus. Our overall purpose is to develop and validate clinical techniques to help people learn how to manage their reactions to tinnitus. We've recently completed 2 trials evaluating the use of hearing aids for tinnitus. This was our first hearing aid study, which was published in 2015 and was funded by Starsky Hearing Technology. The research question was, do combination instruments reduce the effects of tinnitus compared to hearing aids? Combination instruments are hearing aids that also include a sound generator, sometimes referred to as a master. While it has been assumed that combination instruments are more effective than hearing aids, only one previous study had been conducted and results showed no difference. Our study included 30 participants who had both hearing loss and bothersome tinnitus. They all wore combination instruments, but half had the sound generator or master turned on and half had it turned off. They all received brief tinnitus counseling and then wore the devices for 3 months. Research results are reported with respect to whether they are significant or not. That's the key word, and it's based upon the use of statistics. For the Starkey study, both groups, hearing aids and hearing aids plus master, showed significant improvement overall, but there was no significant difference between the two groups. Both groups did about equally well. This is the second study we completed to evaluate hearing aids compared to combination instruments. It was funded by Phonak, LLC, and their devices were used for this study. We asked the same question: are combination instruments more effective than hearing aids for tinnitus management? A third group was added to this study, the Lyric group. Lyric hearing aids are fit deep in the ears, and they stay there until the battery dies when they are replaced. So people wear them all day, every day, and the Phonak company thought for that reason these hearing aids might be particularly helpful for tinnitus. So for this study, 55 participants were randomized to either wear hearing aids, combination instruments, or the Lyric hearing aids for 4 months. They all received brief tinnitus counseling. All 3 groups showed a significant improvement in their reactions to tinnitus. There were no significant differences between the groups, meaning all devices provided similar benefits. So based on these 2 studies, we can conclude that any of these devices reduces reactions to tinnitus. These studies hopefully will influence future Cochrane reviews and future guidelines to more strongly support hearing aids and combination instruments for tinnitus management. I'll now briefly describe 2 recent studies that evaluated progressive tinnitus management, or PTM. The development of PTM has been the culmination of 15 clinical trials that we have conducted at the NCRIR since 1999. Here's our tinnitus pyramid again. PTM is structured to provide services to patients only to the degree that's needed. Level 1 at the bottom is the referral level. Patients need to be referred to the proper provider to get appropriate care. Level 2 is an evaluation by an audiologist. Level 3 is the skills education level, where patients learn coping skills to manage their tinnitus on their own. Level 3 helps at least 95% of patients who receive this treatment. Level 4 is for patients who still have a problem with their tinnitus, and it involves a comprehensive assessment by both an audiologist and a psychologist. Level 5 is for ongoing treatment by the audiologist and/or the psychologist using CBT, sound therapy, and possibly other methods. This was our first major trial evaluating PTM. It was conducted at 2 VA hospitals, one in Memphis, Tennessee, and one in West Haven, Connecticut. A publication describing the study is about to be published. The purpose of the study was to evaluate the benefit of patients receiving PTM Level 3 skills education, the level where they learn coping skills. 300 veterans were randomized to either receive the PTM treatment or to be placed on a 6-month wait list. The PTM group showed significant improvement while the wait list group did not. The difference between groups was significant. PTM was more effective than wait list. This might seem like an expected result, but it was critical to the first trial demonstrating the benefit of PTM. This second PTM study was motivated by the fact that so many patients have experienced a traumatic brain injury, or TBI, and that of these, many have bothersome tinnitus. We used the counseling from PTM Level 3 skills education, and it was administered to participants over the telephone by both an audiologist and a psychologist. Participants were located all over the United States. All of the participants had bothersome tinnitus, and some of them had experienced one or more TBI. They were randomized to either receive the telephone counseling for 6 months or to be put on a 6-month wait list. The tele-PTM group showed significant improvement while the waitlist group did not. The difference between groups was significant. Tele-PTM was significantly more effective than waitlist. These results were particularly strong. We have numerous testimonies from our research participants, and they are almost all positive. I'll just read one of these quotes, which is highlighted. As soon as my tinnitus becomes an issue in my life now, I know how to react to it and continue on with a quality day. I'll pause for just a moment, and maybe you can read one more on your own. So what do we recommend based on all of this work? I believe I've already made the case that every patient is different, and the level of care they receive for their tinnitus should be based on their level of need. Second recommendation, 3 disciplines should be involved in tinnitus management, at least. Audiology, otolaryngology or ENT, and psychology. Third, all patients with tinnitus should have their hearing tested by an audiologist. This is slightly different than what the AAO guidelines recommend, but we believe it is best practice because 90% of people with tinnitus also have hearing loss. 4, is the tinnitus bothersome or not? If so, then tinnitus-specific treatment should be received. 5, the best way to determine if treatment is needed is to complete the appropriate tinnitus questionnaire. 6, make sure the tinnitus problem is not a hearing problem. Many people have both hearing loss and tinnitus. They don't know they have hearing loss, but they do know they have tinnitus. They have trouble hearing, and they tend to blame their hearing problem on their tinnitus. To make sure a person is not blaming their tinnitus for their hearing problem, we developed the Tinnitus and Hearing Survey. It is a 1-page questionnaire that is designed specifically for this purpose, and it gives a good idea of how much of a problem tinnitus is compared to how much of a problem hearing is. This has been a very effective tool, and we believe it should always be used whenever a person with tinnitus has their hearing tested by an audiologist. Recommendation number 8. The first step in tinnitus management is to be informed and to know what is based on evidence and what is not based on evidence. This information is empowering and will enable a person to make informed decisions. Number 9, patients are best served if they learn self-efficacy skills, that is, coping skills. Just like any other chronic condition, tinnitus needs to be managed, and people need to learn what to do to manage their tinnitus. Number 10, people should learn how to use sound effectively to manage tinnitus. There are many ways sound can be used, and as I mentioned earlier, there is no proof that any one method works better than any other. We teach this in our self-help workbook, which is available from the APA. Number 11, people should learn psychological coping techniques. These are techniques based on cognitive behavioral therapy, and they have the strongest research evidence, as I've already mentioned. Number 12, people can be helped by telephone if the provider has the necessary expertise. The beauty of this method is that you would not have to leave your home. You just pick up the phone and talk. So to boil things down, a person with tinnitus should have an assessment consisting of a hearing evaluation and the Tinnitus and Hearing Survey. If treatment for bothersome tinnitus is needed, then the treatment should include self-help education, therapeutic sound, and stress reduction techniques. So the articles and forums I've referred to are available on the NCRAR website, which is shown here. I'm also available by email to answer questions, so feel free to contact me at this email address. Thank you very much for listening, and thank you for your service to our country.
And thank you, Dr. Henry, for your important work that you've shared with us. And now, I want to tell you that I know Dr. Henry makes himself available. I talked to numbers and to individuals who have called or emailed, and so we encourage you to do so. Both of our presenters tonight are very gracious that way. So now I'll ask Dr. Sherlock to come back on, and we're going to have some questions and answers. And you've been sending in some of your questions currently. Now remember that Dr. Henry is on the phone, and Dr. Sherlock we can see. So I'm going to start with the very first question. I'm going to ask you, Dr. Henry. This came in from an individual, and they said that at the nearby VA, they are starting to work with the Distincra device and also I'm trying to kind of look for this one again, and the Tinnitrax next year. What is your opinion of Distincra and Tinnitrax?
Well, Distincra is a company out of Europe, and I believe they have FDA approval to dispense their devices in the United States. I wasn't aware that any VAs were currently using Distincra. I do have to disclaim that I am a principal investigator on a study for the Distincra study, for the Distincra company. However, the study has not started yet, so we really don't have any data to either support or refute any of their claims. I do know they have claims of efficacy out of their studies in Europe, but I would say it's too early to say that Distincra works any better than anything else. And that's what I've said before. Any of these sound therapy devices are generally helpful, but there's no proof that any one works better than any other. And then the Tinnitrax, I think that's a web-based program, but I'm really not familiar with it, so I'm sorry I can't really comment on that. Maybe Dr. Sherlock knows about that program.
Dr. Sherlock, we've got you muted, but I'm seeing that that's not something you're familiar with. But while you're answering, I thought I would ask you, because it's, I think the same person I was asking also said that his local VA has started treatment with neuromonics. So are you familiar with neuromonics, and what's your opinion of neuromonics?
So during the time I was at the University of Maryland, I did treatment with both modified tinnitus retraining therapy and with neuromonics. The underlying basis for both are somewhat similar, and the idea is to sort of reduce the reaction to tinnitus in part by using sound. So neuromonics is a music-based therapy.
And Dr. Henry, do you have any comment or experience with neuromonics?
I don't have direct experience, but I've been in touch with the company over the years, and they have a clever device. It is music-based, and they try to match the tinnitus with the amount of music that you're listening to. So the spectrum of the sound is different than what you would normally listen to. Again, they claim efficacy, but again, there's no proof that neuromonics works any better than any other sound-based method of treatment.
Okay, and real quickly, I'm going to remind everyone that ACA does not endorse any particular product or service or device. And so we are answering questions that are being sent to us tonight at the webinar. I'm trying to do so to assist you with the best answers we can. Dr. Sherlock, is the VA using TRT to treat veterans with tinnitus?
Well, I'm not with the VA, so I'm in the DOD, and right now there is a movement toward sort of disseminating progressive tinnitus management in the DOD system. The DOD itself, to my knowledge, is not routinely used in the DOD military treatment facilities.
All right, Dr. Henry, I'll ask you the same question.
Tinnitus retraining therapy, or TRT, has been around since the 1990s, so it's got a long history. It is used around the world. A lot of clinicians have been trained to do TRT. It has been used quite a bit in the VA. I think it's being used less and less. That's not because it doesn't work well, but there are some complications with CRT. It can be difficult to learn the counseling. So the providers who administer CRT need a lot of training to really do the method well. We've done studies on CRT and we've published a lot about CRT, so we're very familiar with it. However, I think there is more of an improvement towards less complicated methods and also methods that rely less on ear-level devices and more on counseling and coping skills.
Okay, and this one I might need to throw out to both of you one at a time. Dr. Sherlock, I'm interested in learning more about billing the VA and the choice program for tinnitus evaluation and tinnitus care. Any suggestions? Thank you.
Again, I would probably defer to Dr. Henry on that since I'm not in the VA system.
Yeah, so the choice program was enacted a year or two ago as a result of all the problems the VA has had. What they want to do is shorten the wait times for people, and they just want to make access to care easier and better for veterans. And so the choice program, you have to get approval for it. It's not automatic. But if you can get approval, then it would allow you to see a provider who's maybe closer to your home, or a provider who can see you sooner than a VA provider can see you. So it's a good program. It's designed to improve access to health care for veterans, but you would need to contact your VA and apply specifically for what you would like to do.
Okay, and here's another one. In this webinar, we've heard that many people have tinnitus also have depression. However, the AAO HNSF recommendations are against antidepressants. So what should a person do? Dr. Henry?
So, yeah, that's always a little complicated. There is no drug or medication for tinnitus, but we're certainly not advocating, and the AAO is not advocating, that if a person has depression, they shouldn't receive treatment for depression. Now, the tinnitus and the depression, or tinnitus and anxiety, or any of a number of other disorders could be related, but the real issue is do you need treatment for your depression? And if so, then we certainly recommend see a psychologist or a psychiatrist and get proper treatment, which may include medication.
And Dr. Sherlock?
I would agree with what Dr. Henry said. That is definitely an issue where patients come in and trying to figure out if they were already depressed and the depression is getting worse because of the tinnitus, or they're depressed because of the tinnitus.
Well, and in that same vein, we've talked about the medications. This question is specifically that there's a lot on the internet that is available that, are just treatments for tinnitus. Are you aware of any of them that are good?
I'm sorry,
Dr. Sherlock?
I believe the AAO guidelines have kind of looked into that. There's really no evidence base for any of those. Many of those are just supplements. There's no evidence that any of them are effective for treating tinnitus.
There's a lot of the over-the-counter cures, as they call them. That was in the question. Dr. Henry, on that one.
Yeah, it's unfortunate that if you Google tinnitus, that's the first thing you see is just supplement after supplement with all these claims that they will cure your tinnitus or reduce your tinnitus or help your tinnitus. And there really is no evidence that any of them work as claimed. There are studies on different supplements, but there's no study that's shown that any one of these supplements is effective for tinnitus. And that doesn't mean that they're not. It just means that we just don't have evidence to support any of those claims.
Which is exactly why ATA exists. So that is the reason that we present these webinars, is to have science-based information coming to your home and from the scientists and researchers themselves and the clinicians. So tonight I want to thank Dr. Sherlock and Dr. Henry for your generosity of time and effort. They volunteer their time to prepare for these webinars and to present. And thanks to all of you for attending the webinar tonight. To our veterans and service members, another special thanks for all you do. Our next webinar will be January 10th with Dr. David Bagley from Cambridge, United Kingdom. His presentation is entitled Clinical Aspects of Troublesome Tinnitus. And we will also collectively be announcing the Worldwide Tinnitus Awareness Week. We hope to see you in the new year again. Thank you for attending, and good night.